Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. So here's a question. What does it mean to be insured? Most people would say it means you're protected. It means that if something goes wrong medically, you won't be financially destroyed. That's the promise, right? You pay your premiums every month, and in exchange, you get security. But here in Southern Oregon, we've got a growing number of people who are technically insured but remain completely exposed at the moment they actually need care. They've got health insurance cards in their wallets, but when they walk into Asante or any other hospital, they might as well be paying cash for the first $9,000. $9,000. That's not a small number. For most working families here in Jackson County, that's multiple months of income. That's more than most people have in their emergency fund. And yet, that's the deductible threshold that's become standard in the individual and small group market. Today, we're going to talk about what I'm calling the transparency trap, how having insurance has become almost meaningless for routine care, how that creates impossible choices for patients, and what happens when the system compensates for broken price transparency with charity care, nursing labor, and pure goodwill. Spoiler alert, that's not sustainable. Let me tell you about Maria. She's not a real person, but her story is absolutely real. It's a composite of what we're seeing all the time here in Medford. Maria's a self-employed hairdresser. She makes enough to stay above the Medicaid eligibility line, too much to qualify for Oregon Health Plan, but not enough to absorb big, unexpected expenses. She's got an individual insurance plan with a $9,000 deductible. It's what she could afford. It's what was available. On paper, Maria is insured. She pays her premium every month. She's doing everything right. Her doctor orders an MRI, followed by an ultrasound at Asante Rogue Regional. Maria does what any responsible person would do. She calls and asks if the MRI is covered. She's told yes, it's covered. So she reasonably assumes the ultrasound, which is part of the same diagnostic workup, follows the same rules. Nobody can tell her what her actual out-of-pocket cost will be. Not the scheduling desk, not the imaging department, not the insurance company. The systems don't talk to each other in real time. The final cost depends on how the service is coded, what her current deductible status is, and a bunch of other variables that won't be clear until days after the service is completed. So Maria goes ahead. She gets the ultrasound. A few weeks later, the bill arrives. $1,000. It turns out the ultrasound is categorized differently under her plan. It's applied fully to her deductible. Nobody told her this would happen because nobody could tell her. For Maria, $1,000 isn't a nuisance. It's rent, it's groceries, it's business supplies, it's all three. She didn't decline care because she didn't know the price. She didn't consent to the price because it was unknowable at the time of service. This is the transparency trap. Now here's the good news, sort of. Maria's bill is eventually forgiven through Asante's financial assistance program. Asante has one of the most generous charity care policies in the state. She qualifies. The debt goes away. But think about what just happened. The system didn't prevent the harm. It corrected it retroactively. It depended on Maria knowing to ask for help, on having the right person recognize her situation, on Asante's nonprofit mandate and staffing capacity at that particular moment. That's not infrastructure. That's luck. So what's actually going on here? Why does this keep happening? It's not because Maria is financially illiterate. It's not because Asante doesn't care. It's not because the insurance company is intentionally hiding the ball. Well, okay, that's debatable. But the point is, this isn't about bad actors. It's about a system that's structurally flawed. There are three pieces that fit together to create this mess. First, high deductible plans have become the default. Over the past decade, deductibles in the $7,000 to $9,000 range have become standard in the individual and small group markets. For insurers, these plans lower premiums and reduce claims volatility. For employers and self-employed workers, they offer the lowest monthly cost. But here's what they actually do. They convert insurance into catastrophic coverage. Until you hit that deductible, you're functionally self-pay, except you don't get the cost benefits that actual self-pay patients get. Second, transparency rules don't cover you. Federal transparency policy has focused on preventing surprise, out-of-network bills, and requiring price disclosures for uninsured patients. Those are good things. But if you're insured and haven't met your deductible, you fall into a regulatory blind spot. The system assumes you're protected because you have insurance. In reality, you're exposed, and hospitals often can't generate accurate, personalized cost estimates at the time of scheduling, because the final amount depends on real-time benefit calculations that require data they don't have access to. Third, rural market constraints. Here in Southern Oregon, you don't have a lot of choices. You can't easily shop between 5 different imaging centers. You can't delay care and drive to Eugene for a better price. Travel distances, scheduling delays, limited provider competition, all of that reduces your ability to act like a price-sensitive consumer. So you've got high deductibles, no transparency, and no alternatives. That's not a market, that's a trap. Here's what drives me crazy about this. Everyone in the system is behaving rationally. It's the system itself that's irrational. Let's walk through it. Maria's behavior is rational. She follows her doctor's advice. She confirms coverage to the extent possible. She proceeds with care. Without a clear price signal, she can't optimize for cost. If she avoids care, she's exposing herself to health risk and potentially higher downstream costs. If she proceeds, she's exposing herself to financial risk. The system forces that trade-off without giving her the information she needs to weigh it. Asante's behavior is rational. They operate under nonprofit constraints and regulatory mandates. They have to provide care regardless of ability to pay. They have to maintain staffing. They have to meet community benefit requirements. When patients can't pay, Asante absorbs the cost through charity care. This isn't optional generosity. It's embedded in the nonprofit hospital model and reinforced by Oregon law. The insurer's behavior is rational. They design plans to compete on premiums. High deductibles reduce their risk. The costs that fall below the deductible don't directly affect their margins, so they have less incentive to invest in pre-service transparency for those costs. Nobody's acting irrationally. The problem is the incentive structure. The outcomes we're seeing, surprise bills, delayed care, medical debt, charity care dependency, those are predictable results of how the system is designed. So let's talk about Asante's financial assistance program, because it's actually really exceptional and really fragile. Asante is a nonprofit health system. That means they get certain tax exemptions, and in exchange, they're required to reinvest a minimum amount into community benefit activities. Oregon's community benefit spending floor is actually one of the stronger ones in the country. Asante's financial assistance policy is expansive. They offer full charity care for patients under 300% of the federal poverty level. That's about $45,000 for an individual, roughly $93,000 for a family of 4. They offer sliding scale discounts up to 400% of FPL. They automatically discount bills for uninsured patients. For patients like Maria, this can eliminate medical debt entirely. It's a genuine lifeline. But here's the problem. Accessing that assistance often depends on human intervention: a nurse who notices financial distress during discharge, a social worker who screens for eligibility, a billing advocate who recognizes the pattern and intervenes. This works when staffing is adequate and when those staff members have the time and training to play that role. But when staffing is tight, which it is, basically always, here in Southern Oregon, that informal financial navigation role is one of the first things to fall off. Nurses are prioritizing immediate clinical needs, they're managing higher patient loads, they're dealing with state-mandated nurse-to-patient ratios that, while intended to protect safety, also increase operational strain in rural systems with limited labor pools. So what happens? Patients who are clinically stable get discharged without ever learning that financial assistance exists. The system becomes arbitrary. Your outcome depends on timing, which nurse you happen to get, whether they were having a manageable shift that day. We've essentially turned nurses and frontline staff into part of the region's financial infrastructure. That's not their job, and it's not sustainable. Now let's zoom out and look at what this does to the broader system, because the costs don't just disappear, they get redistributed. Medical debt avoidance leads patients to delay care. If you're worried about a surprise bill, you put off that scan, that follow-up, that procedure. Your condition gets worse. Your treatment becomes more expensive. Your outcomes get worse. The system pays more in the long run. Charity care reliance shifts the burden to hospitals. Every dollar Asante spends on uncompensated care is a dollar they can't invest in equipment, facilities, or competitive wages. That limits their ability to attract staff, which worsens the staffing crisis, which makes the financial navigation problem worse. Employer dissatisfaction undermines workforce stability. Businesses offer health benefits to attract and retain workers. When those benefits don't actually protect employees from financial catastrophe, the value proposition breaks down. Workers leave, productivity drops, compensation pressure increases. Public sector backfill increases pressure on local governments. When people can't pay medical bills, when they delay care and end up in the ER, when hospitals can't absorb all the uncompensated care, some of that cost ends up falling on county health programs, nonprofit social services, emergency assistance funds. These are reinforcing feedback loops. Over time, they erode system resilience, and the region as a whole absorbs the inefficiency. So, what are we doing about this now? Mostly, we're coping. Charity care policies like Asante's reduce harm after the fact. Payment plans spread the damage out over time. Informal staff advocacy catches some people before they fall through the cracks. These things matter. They help real people. But they don't change the underlying dynamics. It's like bailing water out of a boat instead of fixing the hole. You might keep the boat afloat for a while, but you're going to exhaust yourself, and eventually, you're going down. All right, so what are the actual solutions? What would it take to fix this structurally, not just patch it? There are 3 big ideas that I think could move the needle, and they all operate before care is delivered, not after. First, mandatory point-of-service cost estimates. Require real-time, individualized patient cost estimates prior to diagnostic and procedural care, regardless of insurance status. This means integrating insurer benefit data with provider scheduling systems so that when you schedule that ultrasound, you get a number. Not a range, not a "we'll bill your insurance and see." A number. Yeah, this is technically complex. Yeah, there are implementation costs, but we've built far more complicated systems for billing and prior authorization. We can build this, and the impact is huge. It restores informed consent. It restores price signaling. It lets patients make actual decisions. Second, automated financial assistance pre-screening. Fully integrate income and program eligibility screening into digital intake workflows. Right now, getting financial assistance often requires you to know it exists, ask for it, fill out forms, provide documentation, wait for approval. What if that happened automatically at registration? What if the system checked your income against eligibility thresholds and flagged you before the bill was even generated? This removes the reliance on chance human intervention. It prevents avoidable billing and debt before it happens. Third, a regional, underinsured risk pool. This is a bigger lift, but hear me out. What if we created a regional fund to buy down deductibles for working class residents? The mechanism would be pooling risk at the regional level instead of the household level. So instead of every family facing a potential $9,000 hit individually, we spread that risk across the community. You'd still have some cost sharing to prevent moral hazard, but you'd cap the volatility. This would require governance, funding, controls to prevent overuse. It's not simple, but it addresses the core problem. Deductibles have gotten so high that they're no longer functioning as insurance. They're functioning as cost barriers. So where does Reimagine Healthcare fit into all this? Look, our role is not to write policy papers and hope someone reads them. Our role is to convene the people who can actually make change: payers, providers, employers, policymakers, and work on concrete pilots. What would a deductible buy-down program look like in Jackson County? How would we fund it? Who would administer it? What safeguards would we need? What would real-time cost transparency infrastructure require? Which vendors can build it? How do we get insurers and hospitals to share data? What's the regulatory pathway? These aren't abstract questions. They're operational design questions, and they require bringing the right people into the same room and aligning incentives across institutions. That's the work. It's not sexy, it's not quick, but it's how systems actually change. Here's how I want you to think about this. The $9,000 deductible isn't just an insurance feature. It's a signal of a system that has shifted risk onto households without providing the tools to manage it. Southern Oregon's hospitals have compensated with charity care. Clinicians have compensated with unpaid labor and emotional bandwidth. Patients have compensated with stress, debt risk, and delayed care. These are not sustainable substitutes for functional infrastructure. If Southern Oregon is going to remain economically competitive, if we're going to retain workers, if we're going to be a place where families can actually build a stable life, we have to treat healthcare affordability and transparency as infrastructure, not as a nice to have, not as something we'll get to eventually, as infrastructure, designed deliberately, funded responsibly, governed regionally. The choice we're facing is not between compassion and efficiency. It's between reactive correction and proactive design. Right now, we're doing reactive correction. We're catching people after they fall. We're forgiving debt after it's created. We're providing charity after the fact. What would it look like to design a system that prevents the fall in the first place? That's the question. Look, I know this stuff is frustrating. It's complicated. It's slow to change. But it matters. Because every Maria out there, every self-employed worker, every small business owner, every family caught between Medicaid and affordable insurance, They're making impossible decisions in a system that's set up to fail them. And when the system fails them, it fails all of us. Higher costs, worse outcomes, less economic stability, more pressure on public resources. We can do better. We have to do better. This podcast is for educational purposes only, not medical advice. I might get details wrong. If you catch errors or have alternative perspectives, please comment. Subscribe to our newsletter at reimagine-healthcare.org. Thanks for listening.